objectives of this presentation is going to be, we're going to have a review about the normal anatomy and physiology of a healthy trachea. And then we're going to talk about the pathological changes in anatomy and physiology of the trachea. And last but not least, we're going to talk about anatomical and physiological changes with tracheostomy. Now, here if you can see, we have a trachea. And if we took a cross section of the trachea, what we're going to see from the posterior side, we have the esophagus. And from the anterior side, we're going to have the trachea. Now the trachea is, if we're going to talk about the review of the trachea, we're going to have the outer lining of the trachea is going to be the cartilage grains. And then the inner lining, which is the glands, the cilia, the mucus glands, and then the esophagus in the behind, and between the trachea and the esophagus, we're going to see here a thin lining of tracheal muscles. Okay, so this is the separation or the organ that separates the esophagus from the trachea. Okay, this is in general talking about the anatomical structure of the trachea. Okay, so we're going to see a video here how the air enters the trachea with inspiration and how the tracheal cartilage helps the lining of the airways to dilate and contract.
The trachea conveys air between upper and lower respiratory structures. This flexible tube extends from the larynx to the upper chest, where it divides into the bronchi. Between 15 and 20 cartilaginous C-shaped rings keep the trachea from collapsing or overexpanding. The shape of these cartilaginous rings allows the trachea to change shape to accommodate masses of food passing through the esophagus. Smooth muscle of the trachea can contract to decrease its diameter, which allows air to be expelled out of the lungs more forcefully during coughing. The trachea divides into the bronchi and bronchioles in the lungs. Relaxation of smooth muscle in the bronchioles during exercise causes them to dilate. This bronchodilation allows greater ventilation. Allergic reactions and histamines cause the opposite effect, known as bronchoconstriction.
Okay, so after we see how the air travels from the upper airway to the lower airway of the respiratory tract, we're going to move on to the pathological changes in trachea. So as you can see here, I'm not sure if I'm covering the screen from you. So as you can see here, we have a lot of types. We have A, B, C, D, E, F. Is it clear for everyone? So in A, we're going to see the normal trachea, which has the laryngeus parts and the tracheal wide pipe, and then the separation of the two main bronchi. And then in the behind, you can see here the esophageal and the stomach. The esophagus and the stomach. And here, and in a superior section of how the trachea would look like in a normal structure, anatomical structure of the trachea. We have the outer lining, we have the inner lining, we have the cilia, we have the tracheal muscle, and the esophagus. Now let's see what happens if there is a pathological issue or a disease. Let's say, for example, here in B, we have tracheal angisis. We have the tracheal angisis is a rare condition, which is, subhanAllah, it's delete or subhanAllah, there is no wide pipe for the trachea. It's only the esophagus and what subhanAllah, it's a congenital disease. So you're going to see the cartilage rings here in the separation of the trachea, but there is no wide pipe. And here, if you see in a superior image, we're going to see only the esophagus. In the tracheal meningia condition, what we're going to see is a weakness on the tracheal wide pipe. You see the cartilage rings is there, but it's weak. It's not supporting, it's not holding the tracheal wide pipe to be strong and supportive. And in D, we have the tracheal stenosis. Tracheal stenosis, where we're going to see a narrowed of the tracheal wide pipe, where it's going to be difficult for air to enter the lungs. And in E, we're going to see the tracheal cartilaginous sleeves, where there is, subhanAllah, no cartilage at all. No cartilage ring supporting the trachea, only the epithelial lining of the trachea. The last image, what we're going to see here, is the tracheal esophageal fistula. This is a condition where the muscle, the trachealus muscle, is, if you can see here, the trachealus muscle is gone. So the trachea is open with the esophagus. So the food will enter the lung, the air will enter the esophagus. There is no normal barrier between the trachea and the esophagus. Okay, so now we're going to move on to what happened if we placed an artificial airway in the trachea, such as tracheostomy. Our course is talking about tracheostomy. So what will happen here, if we place an artificial airway, we're going to change the physiological function of the trachea. Starting with the cartilage rings. The cartilage rings will change by, it's going to be, the trachea will not be depending on the cartilage rings for contraction and dilation and inspiration and expiration. Second, we're going to see the smooth muscles that surrounding the airways. What will happen here? The membrane of the trachea will no longer depend on the muscles to dilate during inspiration, contract during an inflammation reaction. Because there is an artificial airway, the air will go in and out from the artificial airway. No need for the smooth muscles, cartilage rings to do their functional job. The cilia movement, the inner lining of the trachea, what will happen here? The inner lining of the trachea, so cilia, the function of the cilia is to move the secretion and the foreign bodies from the lower airways to the upper airways, so the patient can cough the secretion or cough the foreign bodies. But if we place a tracheal tube or tracheostomy tube, the secretion will be it will be suctioned by a catheter, so no need for the cilia to move and do its subhanAllah, the physiological job. What happened for the nerves? The nerve that's supplying the trachea, the vagus nerve. The vagus nerve will lose the ability